the top of the hour here. Great. Hi, everyone. I'm Dr. Mike Bevilacqua. I'm a nephrologist over in Surrey. And thanks for joining us today to hear about our session all about vascular access for hemodialysis. If this is your first time joining us, welcome. If you're a return viewer, thanks for coming back. For those of you who may be here for the first time or unfamiliar with the format, this is one in a series of these webinars that we do on kind of a rotating schedule with all kinds of different topics. Here on the screen, you'll see a few items. This is how you navigate to where this is in our BC Renal website. Up there, you'll see all the recordings from previous events. This one will be up there eventually too, in case you want to go and rewatch and listen to something again, and a whole other library of all the other sessions. And there's even a little button on there for that you click that says subscribe now, that if you click there, enter your email address, you'll actually get notified every time there's one of these sessions coming up, so you can be sure not to miss them. Before we get started, and although we're joining all virtually, I think it's good for us to think about and reflect on where it is that we are in this beautiful province. Myself, I come from the traditional and unceded territory of the Catheters, Semiahmoo, Fontland, and other Coast Salish peoples. And again, I think each of us, it's worth taking the time to reflect on where it is that we come from across this beautiful province and elsewhere, if that's where you're joining us from. So today, we're going to be doing a whole session about vascular access for hemodialysis. If you've attended some of our previous sessions before, this is something that's alluded to a little bit. We're going to do a much deeper dive here into these various options. And the goal here is really to think about, to hear about these options, and then think about what's going to be a good fit for you so that you can be well informed when you go back and discuss this with your kidney team. As always with these webinars, this isn't meant to replace the one-on-one education or discussions that you have with your team, but really just to give you a good foundation of knowledge so that you're well equipped to go into those conversations. Now, a bit of housekeeping here. Since we're recording the session, it's for that reason that everybody's muted and their video is off. We can't hear you or see you, and that's very intentional for privacy reasons. But we still do want to have you get some questions in. And the way you can do that is if you go on your Zoom in the Q&A box. So that's the one with the 2 speech bubbles rather than the 1. So not the chat box, but the Q&A box. If you type your question in there, what we'll do is I'll collect them. And then when there's kind of a break in the presentation, we'll answer that question. I always try to kind of shape it into into more general questions. If it's a question that's very individual about your specific medical situation, I'll encourage you to take that back to your team. But again, I welcome the questions, and I might kind of shape it in that way if you notice I change the wording in your question. So please get those in. It's very helpful for you to provide those questions for us and for our speakers. And then at the end of the session, a couple of things will happen. One is that you'll get a feedback form and the same email that you registered with. And the other is that if you indicated that you were okay with this when you signed up, well, actually let your team know that you attended, not to take attendance or check on you or anything, but really just to follow up on these conversations that we've had here. So today, we're really going to be fortunate to have a couple of great presenters here. And we have 2 of our expert vascular access coordinators, which is what they do all day long. So we have Danielle and Deidre who are joining us and are going to be taking us through everything you need to know about vascular access. And then one of the parts that I always look forward to the most and that everybody always really enjoys is that in addition to hearing the medical side, we have Bob, who's lived through this experience, and he's going to share his experience with these options with the group here. Again, just to reiterate the goal and to preface the session is to really help you understand your options, inform, give you a good information and knowledge base, so then go back with your kidney team and think about what's the best option for you. And the phrase that we really use is thinking about, if you're doing hemodialysis, what's going to be the best access for you at the right time and for the right reasons. You'll see as we go through this is not a one-size-fits-all type of a situation. It's really about helping to select the right thing for the right person at the right time. And so with that, I'm going to take my screen off. I'm going to turn it over to Deidre, who's going to start taking us through this.
Thank you, Mike. So I'll be talking a little bit about fistulas and hemodialysis. So So hemodialysis is most often done in a dialysis clinic, but it can also be done at home. So what we need is access to your bloodstream so we can clean your blood. So we have several ways that we can do this. These different ways to access your bloodstream are what we call vascular access. So you might end up with several different vascular access during your time on hemodialysis. And if you're already on hemodialysis, then you might understand what vascular access is all about. So how does a vascular access work? Well, we use your vascular access each time that you have dialysis. So we connect your access to the dialysis machine using either tubes or needles. So one of the lines takes the dirty blood out of your body so it can be cleaned by the filter, and then the blood is returned back to your body. So this is a continuous cycle. I know it's incredible, but we end up cleaning about 60 liters of blood in one hemodialysis session. If you can see the picture on the left-hand side there, you can see that the blood comes out, one goes on through the pump. So the little piece on the left there, or sorry, the right is the pump, goes through the dialyzer and then back into the body. So again, this is a continuous cycle. So there's three different types of vascular accesses. The photo on the left is of a newly created fistula. You can see that there's a surgical incision scar right down there by the wrist. And you can already see that that vein has already increased in size. The second image, the middle image, is of a patient with a graft. And you can see that it is down by the lower forearm. And you can also see that this graft has been used for quite some time. The last image on the right is of a patient with a catheter, and the catheter is just sitting in their chest. So Danielle is going to talk about grafts and catheters later on in this presentation, and I'm going to talk a bit more about the fistula. So for most people, a fistula is the best choice. And if a fistula isn't possible, then a graft might be a good choice. And if neither a fistula or a graft is possible, or if, say, dialysis is short-term or temporary, we may even recommend a catheter. So our philosophy is that the patient has the right access for the right reason at the right time. We do recommend a fistula first, if we feel that it is the best option, or if we feel as a team that it's the best option, and a graft next, and lastly, the catheter. But again, it really does depend on what's best for you. So what is a fistula? Well, a fistula is a vein that is surgically connected to the side of an artery. So once that vein is connected to the artery, it becomes bigger and stronger, and then it's able to withstand 2 needles 3 times per week. The vein ends up looking a little large, like a large vein under your skin. So on the right-hand side, the top image is of a mature fistula. So it's been used for quite a few years now, and you can see that there's needle marks going up the arm. The bottom image is that same image that we saw a little earlier. It's a little different angle there, but you can see that the vein has actually increased in size, and you can see the scar there. So your surgeon assesses to see where on your body that the vein or that the fistula should be created. So they usually ultrasound and check out the veins to make sure that they choose a really good spot to put your fistula or to create your fistula. That's right. So fistulas are created by a surgeon in the operating room and sometimes in the radiology suite. The surgeon administers freezing, so you get freezing around the area that they're going to do it, and they often give you some medication for comfort. Ideally, we create fistula well before you need dialysis so that your fistula has time to mature and become bigger and stronger. However, it's also normal to get a fistula created after you start dialysis. This can happen for a variety of reasons such as starting dialysis urgently or changing from, say, peritoneal dialysis to hemodialysis. We usually try and have the fistula created in the non-dominant arm so that your dominant arm could be used for, say, the remote control or your cell phone or whatever you happen to be doing. So your non-dominant arm is the one where we have the fistula. So how is a fistula accessed? Well, each time you have dialysis treatment, we have to insert 2 needles in your fistula. One needle, like I said earlier, pulls the dirty blood out, and then the other needle pushes the clean blood back in. So this, again, is a continuous cycle. So when the hemodialysis is complete, then we remove both of those needles. And so when you end up going home at the end of your dialysis treatment, all you have is Band-Aids. You don't have anything outside of your body. So always remember that if you have a fear of needles, we do have a couple of options to help reduce your discomfort. So in my experience, not that I've ever had needles go in like a fistula or anything like that, but what I've noticed for my patients is there's not really a lot of pain after the patient's been getting dialysis needles put in. After a while, that scar tissue builds up and then the pain is much less. So some patients, I know this might sound kind of crazy, but some patients prefer to put in their own needles. It does sound a bit scary with the thought of that, but it is actually a little easier than you think. If that's something that you're interested in, you should just have a conversation with one of your team members, because it's quite common. Lots of people can do it. It's good. So yeah, when we remove the treatment, or sorry, when we remove the needles, all you end up with is just 2 Band-Aids, and that's what you go home with. So that's always nice. There's nothing left in your body when you go home. So that takes me to some advantages and disadvantages of fistulas. So I'll start off with what are some advantages of a fistula. So firstly, fistulas have the fewest problems. What we have seen in our experience is that they also last the longest, and they're the easiest to look after. We really like that we can prepare hemodialysis in advance, and we also see that the machine doesn't alarm as much as with the catheter. Using a fistula for dialysis provides the best way to clean your blood, and it's nice and easy. It's easy to have a shower and say go to the pool or anything like that, because there's no lines out of your body. And lastly, we really do see that patients with a fistula do feel better in the end. So better dialysis in the end. Okay, so that leads us to some disadvantages. So some disadvantages of fistulas are that a fistula isn't always possible in all patients. So some patients may actually do best with a catheter, and some might do better with a graft. Kind of depends. There are some, there's a few things that it depends on. So also it does take time for a fistula to get bigger and stronger. It can take up to a couple of months to completely mature and get bigger and stronger so that we actually can use it for dialysis. And yes, the only way to access the fistula is with needles. So that might be a disadvantage for some. And sometimes that we don't always talk about is after the needles. So after dialysis, at the very end, we have to take those needles out, and it takes about 10 minutes per needle to stop the bleeding. So we have to add that extra time. So that is one of the disadvantages. And the last disadvantage is sometimes we have to do some maintenance procedure to keep your fistula working well. Okay, so the next slide is going to be of a video of a patient getting a needle cannulated in their fistula. So I'm going to stop sharing my screen, and Danielle is going to start sharing her screen. If you want to look away, you can. So this is a video of a nurse inserting a needle into a fistula. And you can see that on the patient has an orange tourniquet above. And what this does is it helps stabilize and increase the size of the fistula. So she slowly inserts that needle and glides it into the fistula. And then she's going to check it to make sure that the needle has been successfully inserted. Perfect. So then after that needle is in, then we tape it down, and you can see just above that one that there's another area just above where the second needle is going to be inserted. So you end up with one needle pulling the dirty blood out and another needle putting the clean blood in. So that's it for that. So Danielle, take it away.
Awesome, thanks, Deidre. So we're going to talk a little bit about grafts and catheters now. So as Deidre explained, ideally we find a way to make you a fistula well in advance. But for some people, that's not always an option because their veins may be too small. A graft is really similar to a fistula, but it uses a piece of soft plastic-like tubing instead of a vein. As you can see in the top image, the white tubing represents the graft. One end is connected to the artery and the other end is connected to the vein. Now, each time you come to dialysis, 2 needles are placed in the graft. And when you're done, those needles are removed and we put Band-Aids on so that you can go home. Grafts can usually be used a few weeks after they're created, but we now have some that can be used as early as a few days actually after they're put in. As you can see in the bottom image, the graft is just under the skin, nothing sticks out, so the graft is accessed and cared for just like a fistula. Grafts come with some advantages as well as a few disadvantages. They're nice because they don't need time to mature like a fistula does. We only need to wait until the incisions in the arm are healed before we can use them. Grafts have a lower risk of infection compared to other catheters, and they're easier to look after. It's safe to shower, bath, swim, and even go in the hot tub with the graft. By using a graft, we preserve more options for future dialysis access. This is really important because, like Deidre said, sometimes you'll need more than one type of access in your lifetime. Some of the disadvantages are that they still do have to wait for the graft to heal. They're not our first choice when you need dialysis right away. They're more likely than a fistula to have problems with infection or clotting. And a graft may not last quite as long as a fistula because your own blood vessel will heal after we puncture it with a needle, but a graft tends to wear out after a period of time. They can last up to 5 or 6 years though. Like fistulas, grafts also require needles to access them, which can be a worry for some people, understandably. But if you're really scared of needles, we can use a little bit of freezing cream or injectable freezing, and most people find that they get used to the needles eventually over time. Our third option we'll talk about is a hemodialysis catheter. For some patients, it's not possible to make a fistula or graft. And sometimes we don't have enough time to wait for a fistula or graft to mature. So we end up placing a catheter, which is a piece of tubing that we place in through the large vein in the neck, and the end of the catheter sits in the top of the heart. The catheter has 2 openings on the inside, and it has 2 ports that sit outside the skin. One side of the catheter takes the blood out of the body and brings it to get cleaned by the dialysis machine, and the blood is then returned through the other side of the catheter. Catheters are usually inserted in the X-ray department or in the operating room, or sometimes even at the bedside in the hospital. The image on the bottom is of a long-term dialysis catheter that's tunneled under the skin, as you can see here. And you can see in the top image here, there's a little square that actually holds the catheter in place. It causes the catheter to sort of bond with your body, so it stays in and doesn't fall out. Many people, even if they do start with a fistula, sometimes they'll require a hemodialysis catheter at some point when they're on dialysis. They are able to be used immediately after they're put in, so they're really good to have available as an option when we need dialysis urgently. They're also a really good option for people who don't have very many good blood vessels or have conditions that make a graft or fistula not possible. Because they're easy to take out, They're the option that makes sense if you think you might try a different type of dialysis, like peritoneal dialysis, or if you have a kidney donor and you're likely to get a transplant in the future. If you have a severe fear of needles, a catheter might be the right option for you, but I find a lot of people find that this advantage of not having to have any needles is often outweighed by its other disadvantages. One of the most important reasons we try to avoid catheters, if possible, is that they're the most likely type of access to get infected, unfortunately. Because they're a foreign object that sticks out of the skin, they can attract bacteria, and the infections that you can get from a catheter could be quite serious. Because the catheter sits in the heart, the infection can spread throughout the bloodstream and into the body. Catheters are more likely to get blocked up and need to be replaced. And the third reason is arguably one of the most important. Catheters can cause vein damage, unfortunately. They may limit the options that we have for future dialysis access. And that's a really important consideration in a lot of cases because we may require more than one access in your lifetime. People with catheters are more likely than people with fistulas to require a hospitalization. Catheters are more challenging to care for because you're not allowed to get your catheter wet, so you have to avoid swimming and hot tubs. And catheters are more likely to cause machine alarms, which can be kind of annoying for some people. So in summary, we have 3 ways to get you dialysis, and they're all effective. Just some have a few more advantages than the others. I just want to go over them quickly one more time so you can compare the main points of each. The catheter is a tube that's placed in your neck and the tip sits in your heart. It's a good option for immediate and short-term dialysis needs. You must take care not to get the catheter wet when you tub bath. You must not swim or go in a hot tub when you have a catheter. The advantage is that you have no needles needed for your treatments, and catheters typically require more procedures than fistulas or grafts to keep them functioning. A graft is a soft artificial tube that connects your vein to your artery under the skin. It can be used if your veins are not big enough. They can usually be used in 2 to 3 weeks after they're put in, so they're not ideal if you need dialysis that day. But they are a little bit more quick than a fistula. Needles are required each time you come to dialysis, and the needles are removed when you're done. They're safe to shower, bath, and swim with once they're all nice and healed. They require less procedures than catheters, but more than fistulas to keep them running. A fistula is made with your own vein and your own artery, and again, this one sits under your skin as well. They're considered our gold standard for dialysis access, but they do take a bit of time to mature, so they need to be planned and organized well before you need dialysis or before you want to use them. Again, needles are required for a fistula, and when you have a fistula, you can shower, bath, swim, and hop in the hot tub if you like. They occasionally require an additional procedure to get them going, but they do tend to require the least amount of ongoing care. So just what you guys always wanted. In the meantime, I have a little bit of homework for you. Dialysis requires healthy blood vessels, and you can increase the chance that your fistula or graft is successful. I'd like you to look into how you can save your veins. Even if you're not thinking about a fistula right away, it's good to kind of do these steps anyways if you're near or on dialysis. We know that blood work and IVs can cause damage to veins. So please ask the nurse or lab technician, if you can, when you come in hospital or go to the lab, to use your hand veins. And if that's not possible, to use your dominant arm. Like Deidre said, we want to keep the non-dominant arm for a fistula, because ideally we'd create a fistula if we could. So it's really important to start saving your veins well before you need an access. And if you're on dialysis already, please talk to your dialysis access team and have them tell you which veins you should be saving for your future options. On the right, you can see the stylish purple bracelet that you can get at your next dialysis clinic appointment. Ask your team to give you a wallet card and a purple bracelet, and we're hoping that you'll bring those each time you go to the lab or the hospital. So the sooner you guys learn all your options, and thank you guys today for being proactive, the more choices you may have available to you. We've learned that the better informed you are, the smoother your treatment goes. So be sure to talk to your kidney care team about your vascular access options at your next appointment, okay? So now I'm very happy to introduce to you Robert Barnes from the Prince George Dialysis Unit. Robert, or it goes by Bob, I believe, is a dialysis patient that's had a range of experience with dialysis access, and he's kindly offered to share his story and his experiences with us today.
No, it's fantastic. Before we open up to you, Bob, though, there's a few questions. Maybe we'll get those in now, if that's okay. Just so otherwise we don't derail it and people aren't left wondering while Bob's talking, so I can pay all attention to you. So yeah, there's some great questions that have come through here. I'll maybe put them in, Danielle and Deidre, you can maybe pepper back and forth everyone to answer, because a couple of good questions here that people had. So, well, this one comes up a lot. So you mentioned that we need some time, just to reiterate, some time for the fistulas to mature. But on average, so I'll make this a two-part question. On average, how long does that take for that fistula to mature? Just to reiterate.
So I guess I can answer that. I was talking about the fistula. So I guess on average, we have this sort of rule of sixes, and we like the patient to have had the fistula for a minimum of 6 weeks. And so we do some measurements to make sure that it's ready to go, but the minimum is 6 weeks. Sometimes it might take a little bit longer. We might have to do some tweaking, but 6 weeks is our minimum.
Perfect. And then this is the question that always comes as a follow-up is, does that mean that the surgical wound is taking that long to heal, or the person can't use their arm during that 6 weeks?
So we encourage people to use their arm and to do as much as they can. We even recommend exercising that arm as well after about a 2-week period. The sutures, the incision is just like a regular normal surgical incision. Take up the sutures or whatever is in there, that's clips or whatever they use in the OR. They come out in about 10-14 days. And yeah, we get people to use it. The amount of pain that they have is just like a normal, regular surgical incision.
Yeah, perfect. And because that point often it confuses people a little bit that, that maturing process is happening on the inside of the blood vessel. But your arm itself, your hand and everything, you're still able to use. Doesn't mean it's immobile for 6 weeks or something like that. Yeah, it's a really good question. Okay, and then maybe I'll reword this one a little bit, but some of the pictures when we see, the fistulas, they can get quite large, and sometimes aneurysms and things like this. But those pictures that people have maybe seen online, I mean, does that happen to everybody as time goes on? Does it just get kind of bigger and bigger and bigger, or what's the case there?
Danielle, you can answer. I keep answering, so you can.
Yeah, sure. I'm just opening it up, so it's a bit. Go ahead.
Doesn't matter. I can answer.
If you want to bounce it back to me, I can always answer.
No, I can answer.
Sure, you take turns, Danielle.
Yeah, go ahead, Danielle.
Okay, sounds good.
I'll direct the questions. I'll yo-yo back and forth.
Sure.
So from my experience, for the most part, fistulas look like sort of large veins under the skin. They do sometimes get bigger over time, but that's not always the case. Often you can't actually see. All you can see is the needle marks on the arm, but they can expand and they can get larger over time. And that's just due to the increased flow from the artery into the vein. There are some ways we can sort of reduce the chances of that happening through lots of monitoring and care of the fistula, but yeah, that's not always the case.
Yeah, perfect, exactly. And I often tell people that some of the pictures, if you go looking online, that you might see are the most extreme examples, right? The top waves when you go looking online, you see that's the pictures that get put up there, right? Is the extreme ones, but not the average. Okay, and there was a couple, yes, we'll go to Deidre. There's a couple of mentions about sometimes we need to do some procedures. You said, it might not work right away and we need to get some procedures to get it going. Maybe go into a little bit more detail about that in terms of what type of things are we talking about? Are we talking about repeat surgeries? Are we talking about interventional procedures?
There's a couple of things. Sometimes the fistula has like accessory little tiny vessels that might be taking some of the blood away, but while it's maturing and during those 6 weeks, we're monitoring it. And we may have to go in there and do a little, well, we say ligate it, but it's just, we just clip that little one. So it's a small little procedure. It's not done in the OR. It's usually done in, say, ambulatory care. Some people's fistula may not mature, and so the size of it doesn't get big enough to withstand those 2 needles. So we may have to go in there and do what's called, it's called an angioplasty. So this happens in the X-ray department. It's called the interventional radiology suite. And what the interventional radiologist does is they put a needle into the fistula through a cannula, and through there they'll put in a balloon into the area that's narrow. Then they inflate the balloon, and then the fistula, hopefully after that, will increase in size, increase in flow, and then get tougher and stronger so that it can withstand 2 needles for dialysis. So that one's called a fistuloplasty, and the other one is called a collateral ligation.
Perfect. And that fistuloplasty was the procedure that was being alluded to earlier when we said, oh, these might need repeat procedures as time goes on.
Yeah.
Yeah, exactly. And does it ever happen that, a fistula gets created and it doesn't work at all? And if so, how often, might that occur?
So I guess I'd say maybe 20-30% of the time it doesn't actually work. I mean, we would love to say 100%. They always work and they're perfect, but it's not always the case. So there is a chance that, I think it is 1 in 5 that doesn't, I don't know what the provincial average is, but I think that's about it, but 1 in 5 that don't actually work. So
I think we're maybe a little bit lower than that. I think we do quite well in BC here. I just wanted to add too that we do know that the benefits of having a fistula really outweigh the risks, and so even if 1 in 5 doesn't work, we know that it's worth probably trying again. And even though there's that risk, we should definitely try.
Yeah, and I think that maybe 1 in 5 might be more close to talking about, if they're having some maturation issues. When we're talking about just primary failure, like not working at all, yeah, that's usually closer to 10% or sometimes even below. But yeah, exactly right, Danielle. It's for all the reasons that all the benefits, and that's why we actually say sometimes, we need to have a plan for not just this access, but what's the next access going to look like. There's maybe one quick one that I'll just answer because it's about a related topic. It's about home hemodialysis. And the short answer there is that basically, these accesses would apply equally the same to home hemodialysis as they do to facility-based dialysis. And we can train people for home dialysis on any of these. The last question, I think maybe Danielle, maybe you're up. We've been yo-yoing, is so once everything is nicely matured, so the fistula is nicely matured, so let's say even, a year down the road or what have you, do we put any limitations at all in the activity on that arm in terms of lifting or things like that?
It kind of varies site by site, but I think for the most part, we say you can kind of go back to what you were doing before. You want to be a little bit more cautious with the arm. You don't want to do anything with sharp objects close to where your vessel is. But as far as lifting goes, I think we say 25 to 50 pounds is okay if that's what you were doing before. I think it's more that you're not doing something that kind of puts the arm at risk or the fistula at risk.
Yeah, exactly. You just don't, and you don't want to directly compress, but you'll see that most of where they are, if you are to carry something, it's not like it's in the way and makes you unable to use that arm. Perfect. Great. And then the last question, again, I'll just take this one, was that, if we talk about a lot of these procedures being done in local anesthetic and things like that, if it were really an issue, could they use a general? And that's the type of question that I'd say, before you would go in to do this, you'll meet with the team and the surgeon and everything and kind of discuss that, because a lot of that has to do with, it's also an anesthetic risk type of discussion. Whenever we talk about doing a procedure without a general anesthetic, it sometimes seems weird, but the reason that we try to do that if possible is because for a lot of procedures, including this one, the risk of an anesthetic or the risk of putting someone completely to sleep is actually higher than the risk of the procedure. So if they can do it with local methods, that actually makes it a safer procedure. So that's why we kind of talk about it being done that way. But yes, that would be a discussion you have with the team at the time of. Okay, so I just wanted to clear all those questions so that people, weren't distracted in their mind or wondering answers before we could turn it over to Bob. But at this point, I'd love to turn it over, and so we can, if you could, Bob, you could take us through your experience with going through this process.
Okay, Bob, you're up.
What do we start?
Okay, we're gonna start with, I want you to tell me about your vascular or your access journey, basically.
Yeah. Well, I started out, I had the one in my chest and it worked. They left it in until after I got my fistula. But then between that, I had the home dialysis in my belly, which didn't work. I wound up in ER all the time. So then we got fistula, and that's been in 8 months and it works perfect.
Yeah.
Like I feel better. Everything is just way better.
Yeah.
Yeah.
What are the factors that like influenced you to get a fistula rather than the catheter? Because you had the catheter, it was working okay.
Yeah, but I was
So-
still winding up in ER quite often.
Is that right?
Because
not.
water would get on my lungs,
Oh, okay,
and then I'd be in ER, and then
right.
I didn't
So
like it.
you didn't like it, right? So you said you've had the fistula for
That's eight months it's been in, and I've never been in ER yet.
and I think you can kind of see his fistula. We've been putting the needles in this sort of area, hey?
Yeah.
Yeah, it looks good, and it hasn't increased in size or anything.
No, it works good.
Yeah, I think it
It
does.
healed up within 2 weeks. It was all healed. Didn't even know it was a cut.
Where's the incision line?
Somewhere across there.
Oh, so it's right there,
Yeah.
and that's where they attached it to the artery.
Yeah,
So then that's where they attached it, and then it kind of comes up and goes up there.
yeah. Yep, works good. Don't bother me.
Tell me about like the needles. Do the needles hurt or?
For me, I got high pain tolerance, so the needles don't even feel them when they put them in. Maybe one girl out of 100 I might feel, but that's
Okay.
all.
Oh,
And that's if they go through.
Oh, well.
happens.
Hopefully yeah, I know, things happen.
Yeah, it happens.
And then at the end of dialysis, they take the needles out.
Yeah, and they hold for 10 minutes. They take the first one out, and then I hold it for till they get the second one out, and then they gotta hold because I shake so bad. I can't hold them. And other than that, we have the odd blowout, but that's okay.
Yeah, so you hold for about 10 minutes, and then
Yeah.
after they just put Band-Aids on and
They
then,
use gel foam and Band-Aids
okay,
because I bleed so much.
right.
Some people don't.
Yeah, but yeah, okay.
Yeah.
So what do you think is the biggest difference between having a catheter versus having a fistula?
Well, first thing, the fistula keeps me out of ER. And the second thing is, I don't even know it's there. I can do whatever I want, swim, do whatever.
Right, so you,
And yeah.
nothing
it just-
hanging out of your chest
nothing
anymore.
bothers- Yeah, you don't even notice it.
Yeah,
Most people don't even notice it, even.
well,
with the
because yeah, your
sleeve.
shirt kind of hangs over
Yeah.
top of it and don't even notice it, eh? I guess also you talked a little bit about the surgery and that it was a pretty easy
Yeah,
surgery.
for me, it was just like getting my finger sewed up.
Okay, so it wasn't too
Yeah.
big, and then the recovery was okay too?
Yeah, I didn't even know.
Yeah.
Just had a
Did you have sutures in there, or did you have?
They
clips?
had, I think they had 4 staples and 1 stitch. And whenever 2 weeks, they just popped them out and put a Band-Aid on it, and that was it.
Okay, so what do you think is your favorite thing about having a fistula?
I think it works better,
Is that right?
better than both these two did.
Is that right?
Yeah.
And not as many alarms? Do you have?
Yeah, I hardly set alarm off anymore.
Right.
Matter of fact, most of the times I sleep through
You sleep all through dialysis?
it. Yeah.
That's good. Okay, is there anything else that you wanna mention about Oh, what are you like? Oh, I know. Why don't you like having, what don't you like about having a fistula? That's the other question. That's the last one I wanted to mention.
The only thing I find I don't like about it, well, it's not a big deal, it's just takes 20 minutes longer, 25 minutes longer in each session.
Right.
But that's just because you got to hold the needles, and putting them in takes longer than just hooking them up to them little clips.
So a little bit longer,
Yeah, it takes a little longer, but I think it does a better job.
and that's kind of the most
Yeah.
important thing, right? You
I
keep
know
it-
since I've had it now 8 months, I feel way better. And yeah, I'm getting more energy back and feeling better.
That's great. Is there anything else you think that the people out there should know about a fistula?
I'd say
Versus
don't
the
be
cat.
scared, just go for it.
Okay,
I mean, it isn't gonna hurt you.
right. Okay,
That's a really good message to finish with, Bob, there. You know, like anything else, we recognize things are intimidating when they sound foreign, or, you know, they sound like odd concepts, right, to have this procedure done. But yeah, it's great to hear from you that you enjoy it and you haven't looked back. There's maybe one clarifying question, and Bob, I don't want to get too much into your individual background here, but just because the comment came up about, oh, you were ending up in hospital with water in the lungs and things like that. I'll maybe phrase this and see if this is correct. Sounds like that had more to do with how dialysis was going, and it sounds like dialysis is going better with this.
Yeah,
Not-
it is.
Yeah, and so I just wanted to clarify that point, because a couple of people were saying, oh, is that a complication of the catheter or a different type of access?
No,
It's not that it was a problem with that, it's that you're getting better treatment and your dialysis is going better with the fistula.
yeah, these two weren't pulling enough water off when I had the other two.
Yeah.
So,
Yeah, perfect. Just wanted to clarify that point for everyone.
Yeah.
Thanks. There's comments coming through of people, thanking you for sharing your story, Bob. So at this point, again, to everyone, if you have any other last minute questions, get them up. I'm just going to get them in. I'm just going to show a couple little things here. The last couple of information. So one, yes, let us know, and please get your feedback in. Otherwise, just as a reminder to everybody, if there's anything with this session that they want to refresh themselves with, this one's been recorded. Before long, usually within a week or two, it'll be up on the BC Renal website. This is how you'll find it on the webinar section here. You can see all the recording. And then there's a whole host of resources specifically around vascular access on the website as well. So in addition to this recording, you'll see that there's all these little information sheets under this patient resource page. And otherwise, oh, there's supposed to be one more slide. There we are. Please do take the time to get the feedback forms into us. That really helps us shape these sessions as time goes on. And our last plug that we'd like to mention is that if you're going onto that BC Renal website as well, you'll see there's some opportunities if you'd like to get involved in other ways, and we're always looking for engaged people to do so. There's a couple of other questions that are a little bit more specific, asking about, and I'm not sure, Bob, if you want to, if you're comfortable sharing, because I think you had mentioned you've done the peritoneal dialysis at home, but not hemodialysis at home. Was that correct?
Peritoneal. You did peritoneal. How
Yeah.
long did you do peritoneal dialysis for?
I done that for about 4 months, and then it was just wasn't taking enough of the fluid out of my body that I was putting it in.
Yeah.
And then I'd wind up in ER.
Okay. And yeah, so I just want to be clear to the group that Bob's talking about this other one called peritoneal dialysis, not home hemodialysis. Now, because there were a couple questions relevant to that. If that's something you're interested in, again, that is one of those sessions that's available on the website. There's a whole session about home hemodialysis, people who do this treatment at home, if that's something that interests you. Otherwise, yeah, there doesn't seem to be any other questions coming in. So I just want to take the time to thank everyone for this session. I want to thank all of you for attending and taking the time to learn about this very important topic. I want to thank Janet and Alexis from the BC Renal side who helped set this up. I want to thank Danielle and Deidre, who are both for their expertise and for doing this care day to day. This is what they, do and love. So thank you for that work and for presenting and sharing with us here today. And most importantly, Bob, I want to thank you as well. It's always sometimes intimidating to come and share your personal story, but from the comments here and every time, we know people really appreciate it. So thank you for doing so. Otherwise, thanks everyone for attending. We hope to see you at our next session.